And I am joined today by Daniel Saddawi-Konefka. He is a program director in anesthesia at Mass General Hospital, but we are talking him today because he, among with a lot of other people, have created what is called the Emotional PPE Project. So before we dive into that project, you are here as the representative of that project today, but we were discussing earlier that it is the effort of many, many people behind the scenes, and I want to make sure they all get credit. So I want to give you the stage to discuss everyone else that's played a role in this.
Absolutely. Thank you so much, Ferry. It's really nice to join you and everyone else today. Maybe I'll sort of do the emotional PPE an origin story, if that's okay, sort of where it came from.
Yeah, that sounds
So
great.
so I'm an anesthesiologist and an intensivist here in Boston. So we saw one of the earlier waves of COVID back in March, April of 2020. We were about a week after New York, and one of my good friends and neighbors, her name is Ariel Brown. She and I have talked for quite some time, just about well-being, wellness of residents and mental health. It's just a shared interest of ours. She is not in clinical medicine, but is in the healthcare space. So when when everything was coming out about COVID, and I think the big things on the news were, PPE shortage and ventilator shortages. She sent me a text. This is back in March of 2020, and she said, "I want to help. Let me know, how can I help? What do you need?" And it sort of got me thinking, especially given everything that Ariel and I had spoken out about beforehand. I thought, the real shortage here, we'll figure out PPE, we'll figure out ventilators in some time. I think what the real shortage here is going to be is the resilience of our healthcare workers, because the types of things that we were starting to see um, was really unlike anything else we'd seen before, at least in my career. And when you lump that on top of what is the landscape of mental health in healthcare workers to start with, which is, its own epidemic of burnout and anxiety and depression and so forth. It really doesn't make for a good. Nothing good is going to come of that. So with those thoughts just said, I think we're going to need some help around mental health. And she took that seed of an idea, and she has in her family some therapists, and so I think that's probably, just the constellation of things coming along. And she did a social media reach out to see if there were any licensed therapists in the state who would be interested in helping provide free, confidential therapy to healthcare workers. And we piloted this originally with the residency program here. The results were really positive, I think, for a lot of reasons. There's a lot of barriers to reaching out for mental health care that I think the Emotional PPE Project helped circumvent. And from there, she assembled this incredible team that involves some folks with some finance background to help us with structuring of a nonprofit, some folks with some IT background to help put together a website, which is the thrust of the Emotional PPE. Started out as really just a directory. You can go online, and there are volunteer licensed therapists in every state in the country who are willing to provide any healthcare worker free, confidential healthcare, mental health care, which is really an incredible feat. So to your point, Perry, I think the credit goes certainly to a lot of hardworking folks behind the scene at the Emotional PPE Project, and maybe even more to all of our incredibly dedicated and caring mental health therapists who are giving their time to help support this cause.
Within our industry, whenever large change in the suicide prevention world happens, it always seems to happen from a grassroots effort. Somebody identifies an issue or need in their hospital, within their program, within a friend, and it grows because that need is there. What were the biggest things that surprised you when you started the Emotional PPE projects? What were the things that were unexpected and suddenly you learn about within our industry?
That's a really good question. I think I've been surprised in both ways, both the positive way and the negative way. I think in the positive way, the outpouring of support from therapists and other folks who have donated other resources to the project has just been incredible. It's really sort of an inspiring story to know that, in the midst of all of the unrest I think that we have in this country at present, that there are still so many people. We have hundreds of therapists and dozens of volunteers who help with this, and really there's no ulterior motive for them. They're not getting credit. There's no paycheck. It's just they're trying to help. And you always want to believe in the good in humanity, and but it's still always so refreshing in that sort of I don't know if that's a surprise per se, but something very uplifting that's come from this. I think I was maybe also a little bit surprised by the uptake. I think people in medicine, nurses, physicians, and many other role groups really started to use the project and its directory, which I think speaks to a little bit of an unmet need, which is why we've sort of stayed in the fight to help push these things forward. That's a realization that I think is a little bit makes me a little bit sad because there is so much unmet need. And then the other thing, which to be honest with you, Perry, it's the type of stuff that, yeah, I should have known about this before. But as I've been involved more and more with the Emotional PPE Project and trying to help people connect with services, there are so many barriers to accessing mental health care, whether that's time, finances, decision paralysis, or pervasive stigma. It's quite. I've learned a lot of things that I had no idea would impact people's choices around mental health care. But sitting now on this side of it, it's one of those. Well, of course, these are barriers. How are these? How did I not know about them before?
Yeah, there's you speak about something that we discuss a lot during these interviews. There's a difference between providing those resources. Oh, our hospital has access to those, and the uptake of those individuals, and it speaks to the culture and the barriers in place. One of the other things that you've done, and I want to make sure we give you time to discuss this as well, is an article that you published in JAMA looking specifically at state by state levels in licensing and what they do to follow the Federation of the State Medical Board's recommendation in 2018 about how questions should be asked and what services should be provided. Can you talk a little bit about, first of all, what you found when you started to look into that data?
Yeah, absolutely. So Derby and colleagues from Mayo, I think it was in 2017, published an article looking at state physician licensing applications, and found that there was very low, fewer than 50% were consistent with ADA requirements around asking or not asking about mental health conditions. That was before the Federation of State Medical Boards, which is an umbrella organization that provides recommendations to state medical boards. It was before they had put out their consensus recommendations for state medical boards. So we were curious to see, had things changed. In particular, one of the things that Derby found was that in states that were less compliant with ADA, physicians reported, they did a survey as well, physicians reported that they were likely to seek care. They were more fearful of ramifications. So getting the state medical licenses to be supportive, at least in a correlational way, seems like it's quite important. It also, there shouldn't be a whole lot of reasons to not have those consistent with the FSMB recommendations. The recommendation is pretty straightforward, and things like, if I have a history of depression, but it doesn't impair my ability to work, I shouldn't be asked about that. Or if I have a history of a mental health condition that's old, say it was from when I was a teenager or 10 years ago or 5 years ago, but it's really no longer relevant, I similarly shouldn't be asked about that. The two other FSMB recommendations that we took a look at, one has to do with safe haven non-reporting. So each state has physician health programs where physicians, even if they have impairment, can go and contract for safe care of mental health and other conditions. And one of the recommendations from the FSMB was that if a physician is in good standing with a physician health organization, that they don't have to report that to the board. It's called safe haven non-reporting. And the last recommendation was that licensing applications include supportive or normalizing language about mental health and the fact that mental health conditions exist. So what we found was on the one hand reassuring in that things looked like they'd been better since Dearby's publication, but on the other hand, we still have some work to do. So we looked at all 50 states, Washington, D.C., and 3 territories. And within those 54 total areas, 72% of the applications were consistent with only asking if impaired. That does mean, though, is that 28% asked about any condition independent of impairment. 76% only asked about things that were recent. But again, that means 24% asked about things even if they were old. Very few, relatively few asked about or offered safe haven non-reporting, only 46%. And interestingly, especially because this is one of the easiest things to do, only 15% of the states offered any sort of supportive language. So what we found was there's a lot of heterogeneity, and I guess optimistically, that means there's a lot of opportunity for us to get better with that.
Yeah, and I think those findings did not shock me, but when published in a paper, they really put in glaring contrast how different across our country licensing happens on a state by state basis, and the importance of individuals to speak up at their state level to do something. And I think, if nothing else, that paper is a call to arms for all of us practicing across the country. I'm in Ohio, and pushing our state medical boards to say, why aren't we doing this? Why aren't we doing this better? Because what I found very interesting is you have a map of the United States as a table on there where you give everyone a score. And I was looking, and immediately as a physician, you start to compare your state to other states and say, ooh, who's scoring higher, who's scoring lower? But realistically, I think it was it one state that got full marks, that got 4, right?
Yeah, it was just one state, and I'll say there were a number that got 3s, and the one simple thing that they could add is just normalizing language about how mental health conditions. There's no reason to put them in shadow. These are normal things. People have health conditions. People have mental health conditions, and here are some resources. Turns out there was only one state, I believe it was North Carolina, that offered normalizing language. In addition to following all the other recommendations.
The last thing I want to talk to you about is, as a fellow educator, I'm also in a residency program. I'm always very curious to hear about how other programs approach suicide prevention among resident physicians, because we have a very different generation of individuals coming up. They're more open to the idea of discussing mental health, more open to the idea of seeking help, and it's absolutely great. But I want to hear a little bit about what your program has done. Your program director in anesthesia, for National Physician Suicide Awareness Day, and where you think we're headed in the future.
Absolutely. So I'll tell you what we're doing, and I'll say that a lot of these things have been added over time, including I do want to give credit to Lois Swisher, who I know who gave me a really nice sort of crisis toolkit tool that we added to our orientation onboarding this year. So what I do is actually, it's a little bit unusual. We've been doing it for the last couple of years, but I find that it's really effective, and it's very. I think it can feel very uncomfortable to choose to do it, both for me as a program director and likely for some of the residents. But during the onboarding, after we've had some team building, and so people know each other, it's not day one. But it's within the first week or two. I had a session with the residents where I think I just thought, residency is hard. And I talk about how it's hard in general for a couple of reasons. One is because life still happens, and we're all of the residents are now, they're adults and have adult lives with things that can turn left when you expect them to go straight. And it's really challenging because we mostly feel the sense of duty to work. And so the idea that something would go on in my personal life and I would then take time to address my needs, it almost feels like against what we're programmed to do in medicine. We're supposed to put everyone else's needs first. So life can happen. And the other thing I mentioned is that by virtue of the trade, we are going to be put in positions where we see people who are suffering, and we will see people who die. And there's no way to normalize that, to make that feel okay. And to just say that it is okay, though, to recognize that that's not normal and that there are going to be feelings around those. So what I follow that with, Perry, is I tell them about 2 times from my training. One about something that happened in my personal life, and second about a patient who I saw die, a young patient. And those are not stories that are easy to share, and I cannot get through them without breaking down, without crying. But that's the format of it. It's the stories are probably 10 minutes or so that I go through, and then I just stop and I say that I know that I'm not the only one that's had things happen in their lives, and I just offer if anyone has some stories of their own that they'd like to share. And then it's literally silence for half a minute, whatever it takes. But what you find, or at least what I found, is that it's sort of like popcorn. One person will start to share something, and then somebody else will share something, and someone else will share something. And by the end of this hour-long session, it's actually over half of the residents that have shared what otherwise seems like, oh my goodness, how could we have a culture where these sort of things could be publicly discussed? You know, people talking about their experiences with therapy or PTSD or suicide in their family and so forth. And then this year, what we coupled that to is one of these crisis prevention tools where the idea is that you're going to have hard times that come up that you're not expecting. And we give them a worksheet that just sort of has them pre-plan, if one of these situations comes up, what am I going to do? What's my first line? Who am I going to talk to? What are some of the resources that I might think about using? All the way down to what if things are really bad? What's my automated trigger so that when I'm in that moment, I don't have to spend time thinking about should I not? It's a pre-planned, this is what I'm going to do. So we do that, and then we have other things throughout the year. So for example, today we put up in the resident, we call it the clubhouse, but where they hang out, two boards. One of them it says a vulnerability board on it, and it's really just write something about something. So I started therapy myself with a psychiatrist in November. So I put that on there, and then just as a starter thing. Or I think last year one of my kids was sick for a while, which was not something I shared a lot about, and so I wrote about that on the board. And then I don't go in and look at the board; it's just for the residents to share with each other. And then the other board, it says "Talk to me." I've used ... and then there are a bunch of different buckets. So a therapist, peer support, EAP, Emotional PPE Project, and so forth. And people just write their names up there for what they've used, to both normalize the fact that people use these things, and then also create an opportunity for a community. If I've been thinking about using one of these things, maybe these are people that I could reach out to. The last thing that we did today, Perry, was we actually, you're probably familiar with the idea of, like, here's a case stem, a clinical case. How would you approach this? We do that all the time in medicine. So we created a case stem around a colleague in trouble. You are showing up or you've been working all day, your night shift counterpart shows up, and they don't look as they normally do, and you unpack it, and there's some stuff in the background, and I'd be happy to share this with you. And then they have all sorts of concerns about reporting it to anyone, getting help for any of this sort of stuff. They've maybe been underperforming a little bit and they don't want to shine the light on themselves. And so what do you do? So that's the clinical case stem. And then we provide a bunch of possible answers. And that's just in a stack of those papers in the clubhouse table with some snacks and other things to sort of bring attention to it, with the idea that hopefully the residents will take a look at that and maybe it'll make an impact for someone down the line.
Yeah, I absolutely love that. You hit on 3 key points that I think are so important. I'm gonna kind of focus on those a little bit too. The importance of vulnerability from people in leadership positions. This idea, and it's so pervasive in our field of physicians saying, well, I went through this, so you have to go through this. That we are supposed to be perfect and we never make mistakes and we get everything right all the time and we never have weakness is so broken, is so wrong. When we set that as the standard and the expectation for our younger learners, they create maladaptive, coping mechanisms. And instead, if we do what you do and become vulnerable as people in leadership positions, showing that we are human and these things happen to us too, suddenly we create that culture in which that conversation is so important. The second thing you talked about, the safety planning, which is something I absolutely love, that worksheet that you do, because there's so much stigma in health seeking among physicians. But if at a minimum, we can create a safety plan for our residents that tell them, hey, this is private, only you use it. No one else knows if you use it. You don't need to tell anybody if you use it, but it gives them tools on what they can do. And it's personalized just to them, to what works for them and the people that are important in their own lives. And the last thing that you do is creating that environment where there's that open conversation and that peer-to-peer safety net. Here's somebody you can talk to. Here's somebody you can discuss it with. It's absolutely incredible. What you've done is amazing. And it is something that I think should be copied at every program around the country. I absolutely love it. Um, Thank you so much for your time, Dan. And I really appreciate it. And if no one else has told you recently, thank you for what you do with your residents. It is amazing. I'm sure it's an incredibly training program, and your residents are leaving with tools that they then can go out and change lives of everybody else that they touch. So thank you.
Thank you very much. I couldn't agree more with everything you've said. And if you know of any other things that we ought to be doing, we're always looking to get better. I worry a lot about my residents and who we're missing, and it's this feeling that you really can't ever do enough for this. So thank you.